So thank you for the invitation to speak today. I think my story is slightly different, and I think what you're learning as you hear all of us speak is that there's no one way to do this. There are lots of different pathways, there are lots of different journeys, but what you're hearing is that we all love what we do. We find it really exciting, and we're hoping to inspire you all in all of our different ways. So I'm going to start with where I started. So I was born in Fiji. My parents were GPs in Fiji, and they came to Australia to Darwin in the aftermath of Cyclone Tracy, where medical doctors were much needed, and they took that opportunity. From Darwin we moved to Adelaide, and that's where I did my medical training, at my high school and medical training, so I'm a graduate of the University of Adelaide. I then undertook my nephrology training in a number of the hospitals here, and I was inspired to nephrology after I had actually spoken to the head of cardiology and decided that I wanted to be a cardiologist. My next rotation as a physician trainee was nephrology, and I completely fell in love with nephrology. Those of you who know or who've met Professor Leo Ma, who was the cardiology head of unit at the time, know that my challenge was very difficult to go back to him after saying that I wanted to be a cardiologist and actually say, look, I'm really sorry, I've made a big mistake and I don't want to be a cardiologist at all. I've fallen in love with nephrology. That shows you that sometimes there are sliding doors moments in your life, and it's really important to acknowledge them when they come along. So I did part of my nephrology training, which I then finished off in the UK in the renal unit at St Mary's, the renal and transplant unit, and that actually doesn't really exist anymore. It's been subsumed into a very large conglomerate of hospitals over there with the Hammersmith and Charing Cross. But when I was there, St Mary's was a really fun place to work. Just opposite, across the road, was where the royal family have all of their babies, the private hospital there. So that was very exciting. Every morning I'd walk past the lab where penicillin was invented or immune tolerance was discovered, by Brent and Billingham, and it was a wonderful place to be. We were doing some really exciting things at the time in the world of islet transplantation, which hadn't really taken off. And I was there when they did their first blood group incompatible transplant, and I stayed up all night with that patient to see them through. So that was really exciting. And when I came back to Adelaide, I was the person who had the most experience with that transplant, even when we were setting up our program. So it was. We also had an opportunity to travel a lot, so there were some really fun times, and it was a really, really valuable part of my life. I returned to Adelaide because Adelaide does tend to do that to you. You've heard from many people that they've gone away, but then they get drawn back. And I undertook my PhD again with the University of Adelaide, and then for about 10 years after that, I've been a 0.5 staff specialist at the Royal Adelaide and went up to a full-time position last year. So that's a bit of my background of where I started. So I just want to take you through how it's going for me now. And I'll preface this by saying I absolutely love my job. Well, you can see that we're all really busy. I'm not sure we're all as busy as Pete Saltis, but we're all pretty busy. And my schedule doesn't quite look like his, but we do a lot of stuff, and it's busy and it's exciting and it's really rewarding. So primarily I'm a clinician. I'm employed by the hospital to be a clinician. Research is a small expectation, but actually I don't have protected research time. I'm not on a fellowship and I don't have an academic appointment. So clinical work is actually my bread and butter, and I do have to deliver that, and that's very important. I do general nephrology. I've done time on the transplant team. I look after a lot of patients with CKD and dialysis. I'm also an obstetric nephrologist, and I'll be talking a bit about that in a moment. I'm on a number of management committees in our unit around keeping our clinical service really top-notch and making sure that we're delivering for our patients. And as part of that, I've been involved in a very large piece of work setting up our clinical database so that we can actually look at our clinical outcomes with a lot of granularity. I do a lot of research, and I'm going to talk to you about two of my research programs that I've started within the Royal Adelaide. I also do a lot of work here at SAMRI with the ANZ Data Registry, and looking at outcomes for dialysis and transplant patients. ANZ is a national registry, and we're privileged that it came out of the renal unit at the Queen Elizabeth, moved to the Royal Adelaide, and now has found its home in SAMRI. I do a lot of work around Aboriginal kidney health, and this is a very important part of what I do, and it's been a really wonderful journey for me to work with community members in that space. I'm involved in a number of clinical trials. We have a strong pharma clinical trial history in our unit, but actually what I've been able to bring us some investigator-led clinical trials that might not make the big bucks, but are actually answering some really important questions for patients. And I do a lot of work in the consumer engagement space, particularly consumer engagement for kidney disease research. So this is a really fun part of my life. I teach primarily in the postgraduate space, so physician trainees. So I ran the renal physician trainee program for a long time, and in that time supervised over 140 or so basic physician trainees who came through our unit. I supervise advanced trainees in nephrology as well. I do a lot of teaching work and speaking at meetings, etc., for the professional societies I'm involved in. I do some undergraduate teaching, particularly on the wards. I do a lot of primary care teaching, particularly around early detection of chronic kidney disease in the primary care space, which is absolutely critical to preventing the tsunami of kidney disease that we're about to face. And I do some work in Fiji as well, which I'll talk about in a moment. And I think the service work that we do is critically important, and I think it takes all of that knowledge that we have being clinicians and researchers and trying to improve the systems that we're working with. So I chair our Safety and Quality Committee, and we've got quite a large agenda around quality indicators in our clinical care that I'm leading at the moment. I'm involved in a lot of external committees and task forces, some local, some national. For a few years I was the Medical Director of Kidney Health Australia, and I'll talk about that a bit later. I am the chair of the advisory group for KTDRA, Kidney Transplant Diabetes Research Australia, which is a charity with the Hospital Research Foundation, and we have philanthropic funding that we make important decisions about, and we try and support the Hospital Research Foundation in the work they do. And I'm an editor, or sub-editor for a journal, an international journal where we try and promote, in particular, research from lower and middle income countries. So I really want to say that it's diverse, but it's important to know that I don't do all of this every day. In fact, most weeks I don't do all of this every week, but this is what you can get involved in as a clinical researcher, and it's your choice. I have a lot of autonomy in what I do. I control the agenda of what my work life looks like, and it's a very exciting role to have. But it's not a linear journey. I didn't wake up in 1999 when I first did my physician's exam and say, this is where I want to be in however many years' time. And the road is very long and winding, and I've particularly chosen this road because you can see that it goes backwards sometimes. So I've had some good luck, I've had some bad luck. I've had a lot of serendipitous findings. There's been some hard work in there, in fact quite a lot of hard work, but as others have said, hard work is not everything. I've had some fantastic mentorship and opportunities put my way, and some of it has been strategic, but not all of it. And we shouldn't pretend that it's all strategy, because you can't control the narrative entirely as to what happens to you in life. So I thought I would start with talking about the challenges of being a clinician scientist, because you're naive if you go into anything without having a really good understanding of what the challenges are. Once you know the challenges, you can work really hard to address them and overcome them so that they don't become the challenges that stop you from doing what it is that you want to do. And I think as a clinician scientist, certainly the clinical workload is the greatest competing priority. I'm on call at the hospital at the moment. We've had a bit of drama today. I've been on my phone, running in and out of this session, and that's how it is. And the patients will always come first, and patient care will always come first. The other challenge is finding protected time for research. We've had a lot of discussion about that today. We've had a lot of discussion about the different models in which we can improve that. For me, I worked 0.5 for a lot of my my consultant career for lots of different reasons. And when you're a 0.5 clinician, there is actually no fat in the system for progressing research. So you do a lot of work in your own time, and I have progressed a lot of my research agenda by working in unpaid time, and it was an absolute delight to go up to a full-time position at the Royal Adelaide and get some of that fat back into my life. But that shouldn't stop you from making time for research and pursuing something, and that's where the passion comes in. Funding is one of the greatest challenges that we all face, and it's lovely to get Category 1 NH and MRC and MRFF funding, and I do have some of that. I have relied a lot on philanthropic funding from various agencies and from within the hospital as well, and that's been absolutely instrumental to getting research programs up and running. And really it doesn't matter where the dollar comes from, because a dollar is a dollar. But my greatest source of funding is the in-kind support that I get from people within my clinical service, and we function really on the smell of an oily rag, which is an interesting model. It's a challenging model, but I think we can achieve quite a lot by tapping into those local funding sources. There is this immense pressure to publish or perish, and I think getting publications landed is one of the greatest challenges that you face when you're a clinician, because it's the last thing on your to-do list, and if you're strategic it should be the first thing on your to-do list, but it can be quite challenging. And the entire time what you are battling is trying to avoid the leaking pipeline of attrition. There are a lot of clinicians who do their training, they go and do PhDs, and then they never really take the next steps and into establishing themselves as clinician researchers, or if they do, and particularly for women, as they progress in their careers, we know that the women fall away, and there's been a lot of focus from NH and MRC on why that is, and I'm pleased to see that focus is happening. So these are the challenges, and sometimes it can feel like an uphill battle, but you just need to know what they are, and you need to know how you can try and deal with them. And the reason to do that and to persist is because this is a fantastic job to have. We are very privileged to be able to do the work that we do, to take the knowledge that we have, grow it, and then take it back for the benefit of our patients. I am never bored. I don't think there's anyone who's spoken today who's bored in the work that they're doing. It is constantly stimulating, and having all of these different roles means that you have a lifelong love of learning, and you can learn. I learn something every single day. I'm constantly evolving into new areas. There is, I think someone said earlier that, surround yourself by people who are much smarter than you. And I think if you're finding that you're in a place where you're the one who knows everything and you're not learning from the people around you, then you're in the wrong place. So you need to make that move. And really, at the end of the day, we as clinicians are best placed to translate research knowledge into care. I think we've heard many stories of that today. I think that we who are at the coalface of care, it is incumbent upon us to take research knowledge and put it into practice. And if you're not doing that every single day in your clinical practice, then you're not serving your patients the best that you can. Now, there is a research spectrum going from all the way from absolutely, no research engagement at all, and that's Dan on his yacht, with his $9 million, that he could have done. And then there's people who are doing only research, and we need those people. But there is a spectrum, and you just need to find where you're going to sit. Any level of research engagement as a clinician is better than none at all. Every level of research engagement brings some value, not just to you, but to your clinical practice. And I think that's a really key take-home message for all of the up-and-coming people in this audience, that it really doesn't matter, just get into it. So I've got a few lessons that I wanted to share with you about, what I think is really important. And the first lesson is don't be afraid to start. You have to start somewhere. So we've got a diverse group in the audience, all at different career stages and different backgrounds. For me, as a medical student, I started off doing some surveys. As a basic trainee, I was doing these, basic clinical audits that Pete Soltis was told to do as sort of research. It kind of got a bit more advanced through my nephrology training, and I started doing registry analysis, and that was my first paper, and I started doing some cohort studies. Now, did any of this really change the world? That none of this was going to get me a New England Journal of Medicine paper? Of course not. The thing that it changed was me. It taught me how to get some runs on the board, to cut my teeth, to get over that learning curve. Everyone who starts in research is going to have that learning curve, and you need to get over that quickly if you're going to be serious about research. So start early and don't be afraid to start. But also, just as importantly, don't be afraid to stop. So I'll tell you the story of my PhD. So I came back from the UK and was looking to do a PhD. I knew I wanted to do a PhD, and at that time in nephrology, most of the PhDs were in the basic science space. There was very little in the way of properly developed clinical research in nephrology at that time, even in the space of clinical trials. So nephrology is a very young specialty if you really think about it. So at the time, the only PhD project in nephrology in Adelaide that was going was at the Queen Elizabeth Hospital in the Transplant Immunology Laboratory with Toby Coates, who was a fresh postdoc who'd come back from his time in Pittsburgh and was looking to set up his lab. That was the only PhD, so of course that's the one that I did. And the project that I started off doing was quite different to the one that I ended up doing, but essentially we were looking at a non-human primate model for studies of transplant tolerance. And a lot of my work involved getting to the point of developing dendritic cell immunotherapy in this non-human primate model, so that when we started doing transplants in this model, we could look at how we could induce immune tolerance. So this was several years of work, genotyping the colony, looking at their HLA, trying to grow their dendritic cells and look at next bits and pieces. So I then had a whole range of projects that came out of that looked at different ways of manipulating the dendritic cell biology. I even started to look at dendritic cells in preeclampsia and pregnancy, but really got to a point where I realised that I wasn't passionate about this area. This was fascinating, this was interesting, but this was not my key passion, and I wanted to move into clinical research. At that time, we had a lot of work happening in clinical trials, in our lab, in the registry, but there were there was a big gap for clinical research at the coalface of care, and so there were two programs that I got going. The first was around pregnancy in women with chronic kidney disease. We had just shifted from a paradigm of women being told that you mustn't ever get pregnant when you've got kidney disease, to maybe being a little bit cautiously optimistic and letting these women have babies. So quite a paternalistic model. There were a lot of questions that these women wanted answered, and there was a lot of complex decision making that had to happen around these pregnancies with chronic kidney disease at all of the different stages, particularly for transplanted women. And what I wanted to do was try and get an evidence base to help navigate those women. We started an obstetric nephrology clinical program, which I've built up from not having one at all in South Australia. Over 10 years, we now have obstetric nephrology at multiple sites. We've trained lots of local registrars. We've seen lots of patients and navigated these women to successful pregnancy outcomes, even with very complex pregnancy conditions. We've raised the profile of obstetric nephrology across Australia, and it's now really embedded as a thing, and that's something that has been we're now about to translate to an international level through a train the trainer program. So you can really take something small and build a big clinical program by sort of starting somewhere and then slowly growing it. We've also done a lot of research work around defining patient and clinical perspectives, looking at data and assessing risk and building better data systems for the future. A lot of it here at SAMRI with the ANZ data registry, and we've now got lots of global collaborations, and we're starting to embed the models of care that we've developed into clinical care. So starting with the patients, doing the research and then taking it back into the clinic. And this is, of course, why we do it. All of these wonderful babies who every single one of these mothers was told, except for me, because that's me as one of the pictures up there, they were told that they shouldn't have a baby, and we've been able to navigate them to this successful outcome. The other research group that I've started is the clinical research group at the Royal Adelaide for our renal unit. I established this in 2015 out of frustration at the lack of patient-centred clinical research embedded within our unit, and that is the goal of this service. It's very multidisciplinary. We're building lots of collaborations, and we're really embedding a culture of research into our daily clinical practice. So we have a number of streams that we've been developing over the last few years in a range of different areas, and lots of different projects that are now developing in a very diverse range of domains to do with helping patients with kidney disease live the best life that they possibly can, and addressing some of their symptom burden and some of their care needs and the models of care that we can deliver for them. Now, I don't lead all of these projects, but I'm involved in them all. I lead some are with collaborators, some have Category 1 funding, some have no funding at all. It's a diverse range of studies, but each and every one of them, the goal is to bring something back into our clinical unit, to change something in the care that we provide. And this program is really starting to cook with gas, and I think we're building a good momentum. And we've been able to do it because this group collaborates way beyond our field. I have found that it's much more fun to work with people outside of nephrology than it is to work with people in my own specialty. I do a lot of nephrology collaborations at a national and international level, but a lot of this work has been bringing people from this whole biomedical precinct into our renal unit to teach us, to collaborate with us, and to actually build better care for our patients. And we're now having PhD students coming through, we're getting grants, we're publishing, and we're starting to achieve that research translation. So there's a lot of people involved here, a lot of different groups, and these are wonderful collaborations that we hold. I also firmly believe in putting patients in the driver's seat. The patient need is a great motivator as a clinician researcher, and consumer co-design, we know, is now required in a lot of the work that we do, and it makes our research better. And shortly we'll be launching a Centre of Research Excellence around partnering with patients with chronic kidney disease research, which I think is really going to elevate all the work that we've been doing in this space to the next level, and that's launching in November. It's really important to try and be the soil, not just the flower. I'm a very, very keen gardener, and I know that if you can have a really good fertile soil, you will grow the next generation of clinician scientists. With the right support within institutions, within hospitals, where research is valued and prioritised, you've got some time, you've got some money to get started. And with that, you can build capacity, you can invest in people, invest in the teams around you. You know, the clinical workforce is a great workforce to leverage for good clinical research. And if you plant many seeds, some of them might grow. one of the seeds we've planted is nephrology in Fiji. So before he died, my father set up a medical school in Fiji, and I remain, he built it, he funded it, and it's now delivering doctors to Fiji, and I remain engaged there, and I've been involved in supporting nephrology grow from nothing to Fiji now having a couple of nephrologists and a big program growing. So that's been very satisfying. And my final comment is jump off a cliff at least once in your life. Go off and do something completely different. And for me, this was to become the clinical director of Kidney Health Australia. It was a job that I was tapped on the shoulder to do. I did this for 4 years, and in that time learned a lot about being a media spokesperson, engaging with government and developing policy. And in my time we set the national strategy for kidney disease. So that's taking all of my research knowledge and putting it into policy that will then benefit patients. So they're my take-home messages. I have enormous gratitude for all my mentors and enablers and the funders, and I encourage you all to take that leap into research in whatever way you can. Thank you.